afternoon, Till. Thank you so much for joining me for a Corona conversation. It is Monday, May the 4th, 2020. And could I just ask you to introduce yourself and where you are in the world and what you do for a job?
Yeah, good afternoon, Adam. Thank you so much for inviting me to have this interview with you. My name is Till Kinkel. I'm based in Berlin. I'm currently sitting in Berlin. I'm currently working in Berlin. And I'm running a clinic for people who use drugs, mainly opioid dependence and a bit anything else. But our main focus is opioid substitution therapy as well as diamorphine therapy in Berlin. Yeah, that's where I am.
But you've come with an awful lot of international experience. So I know you previously worked in Afghanistan and you've helped set up methadone services in Nepal. So you're used to working in challenging environments, which is
that's definitely true. I mean, I started actually my career even when it comes to substance use disorder and care for people who use drugs in more challenging environments like Afghanistan, Nepal, but also other parts of the world. In Berlin, we are actually relatively spoiled people, right? We have relatively good access to relatively good services here.
So tell me, what's been the impact so far of COVID-19 on people who inject drugs and use heroin in Berlin?
Yeah, well, that is indeed the most important question you ask first, right? That we analyze a bit the situation because that differs from setting to setting, right? And in Berlin, we don't see outbreaks of SARS-CoV-2 among people who use drugs yet. And I don't expect them to happen. I don't see SARS-CoV-2, or I don't see people who use drugs as a particularly high risk of direct effects of this virus on the people. If we talk about the attributable risk of substance use disorder to the overall burden of disease, probably nicotine use disorder and maybe cannabis use disorder have a stronger impact than opioid disorder. Once it comes to the direct effects, right?
Yeah.
I mean, what effects? Who are the people at risk of COVID-19? These are people who live in old age homes, or who are doing holidays on cruise liners, or visit football stadiums. In Berlin, the tremendous effect COVID has on people who use drugs is an indirect effect, right? And when it comes to indirect effect, in Berlin, we have currently not a problem with the supply of drugs, but what we do have is a big problem with people getting money to buy drugs. Because, right, shoplifting is not possible when the shops are closed, right? Or begging doesn't work, selling newspapers in metros doesn't work when the metro is actually empty. Sex work in brothels is it's closed in the street, it's forbidden, right? So what we see here is actually that people don't have any sources of income to buy drugs in the street. And that increases a lot of, that creates a lot of problems, right? And this is as well why people now come to substitution treatment, because the demand is much higher than before, because the barriers to good drugs have increased, because they don't have the money anymore, because they don't have the sources of money anymore, right?
Have treatment services in Berlin been able to expand rapidly to take on those people who are now seeking treatment because they can't afford to buy illicit drugs?
Yes, there was a relatively rapid response of the authorities, which is in that case the Chamber of the Medical Doctors, who actually, before we had something like a limit how many patients can be treated with opioid substitution therapy by every doctor, which was usually some 50, 75 or 100 patients. And this limit has been completely cancelled. Now you can take care of as many patients as you want. just because there is a higher need, right? And so we could actually accept patients without actually being in need of free spaces, so to speak, right? We could just say, yeah, come, I take care of you. That was.
Have you been giving people more unsupervised doses, more takeaway, so they don't have to come to the clinic and the pharmacy every day?
Well, we have now it's much easier in terms of law. We are allowed to give more take home than before, and the regulation.
How many days worth of medication?
Well, there was before the rule that we can give up to 30 days in exceptional cases, right? This exceptional cases was in brackets, it is an exceptional case now. So before we had somehow to justify why are we giving this person more than 7 days, 14 or 30 usually. Now we can put more or less the SARS-CoV stamp on it. However, I don't do that so often because, you know, for me, it was before already like that I had a take home quote of 80% of my doses were given take home because Pardon?
That's very high.
That's very high. And I really support my patients with being free to live their lives. And wherever I can actually justify that a patient or that I expect that a patient can reasonably deal with the situation to have 1 week methadone in their pockets, and most people can do that. Okay. I give take home. I'm very, very open to take home independently of COVID-19. What I don't do is that I give to patients who are actually in need of my care, of my conversations, of me looking at them, that I give them now take home just because there's COVID around, because, you know, the need of care is still there. It might be even more than before. And one of the sentences I would like to say is, you know, when people you take care of or you care for have an additional problem, then you should care more and work more, not less. And what I see now is that some doctors say, well, okay, now I can give everybody one month take home and I don't have to care anymore. No, the opposite is true. No, we have to care more. That means I do maybe more bring home methadone. And also this rule is now easier in Germany, simpler. I mean, before you had to have trained nurses or the doctor himself bringing it home, and it was actually only allowed to get money from the insurance as a payment for it if you do it for the purpose of another disease. And now you can actually send trained lay workers. It's much easier. However, I do it as well myself. If there's a person at certain risk, that means an older person or a person with hypertension, obesity, or chronic obstructive lung disease, or a person with symptoms of an upper respiratory tract infection.
So it sounds like, Till, that you already had quite a flexible system. The government has allowed that to become more flexible, and your practice, which was already very client-centered, has become more client-centered. I want to go back to something you said right at the beginning. So while I accept that there's a lot of indirect effects of COVID on the economical sustainability of an illicit drug habit, you said that you didn't feel people who injected drugs or were using opiates were particularly at risk of COVID. So I'm going to challenge that just for the hell of it. If you don't have a roof over your head, you don't have the ability to socially distance or wash your hands. And if you have compromised lung function from smoking cocaine or heroin or tobacco, surely you're going to be more susceptible. You're going to be immunocompromised, as well as, you know, more likely to bump into people who are less able to take care of their health. Why is that not the case?
You know, I don't want to say that this is not the case at all. You're right. I think people who have destroyed lungs, people who are heavy smokers, have an increased risk. And I think even smoking, indeed, is increasing the risk And there are even now some data on the way how this happens, right? However, pure opium use disorder, how do you get SARS virus? By being in an overcrowded setting in closed rooms, and I don't see that as a particular habit of the population I take care of.
They have their own room, they have space, they're not left in crowded.
Even if they don't have a room, I think living on the street is not really a risk factor for COVID. But when we look as well at the people's average age who die in Berlin from COVID-19, the average age is 82, and there were only a handful of cases of people who were younger than 50, and this handful of cases had severe comorbidities of the heart or the lung, right? But most of my patients are 25, 30, 35, 40, 45, and they have a hell of a number of risks, health related. But COVID, even if it's now around all over the world, is not directly affecting them so much. And in the past 6 weeks, I have seen 2 severe cases of diseases among my patients, and one was an influenza and one was a non-Hodgkin lymphoma, but I have not seen a single infection of SARS-CoV-2 among my patients, and I was screening many. I haven't seen it.
So it's interesting. Germany has obviously managed COVID very well. You have a particularly low mortality, and it sounds like that country-based public health approach has already filtered down and is effectively protecting what would otherwise be a very marginalized group. So my next question is this. There have been positive changes in the way you can work and engage with people now. What is your hope for longer term policy and treatment change once COVID becomes less of a priority and, you know, something that isn't dominating our every waking hour?
You know, my hope is that what we see currently is perceived as a huge study proving that there is nothing wrong with breaking down the barriers radically, the barriers to treatment, with breaking down the barriers to take home radically, and just recognizing now that nothing bad is happening if we give responsibility to patients who can take responsibility as any other patient can do. You know, one element which is as well quite interesting, and even I find it revolutionary in a way, is that in Germany now we have a governmental body from the state of Berlin where you can go, even if you have no residence, even if you have no passport, even if no name, no insurance, and you get a paper that gives you the right to get into substitution treatment, and that works within hours that I start treatment. And this is very often homeless people from Romania, from Bulgaria, from Poland, so European Union countries who very often have no insurance in Germany, and they can go to this center and they get registered in a way, and they pay for the medication, they pay for the doctor. And I accept, for instance, this week I have 5 patients on my list who come through this channel into my office. And, you know, I love having this in my country, in my city, and I hope that they will never go back to what we had before, a state of missing this opportunity, right? And having people living in the street because they don't have insurances, even in Germany. And the same is true for Takehome. No, I mean, I have done a lot of Takehome before, and we have, for instance, we had the rule, as in most other countries, you can give Takehome only if there is if the patient is free of consumption of other illicit drugs or alcohol. I mean, now we are much more liberal, and we will see that this criteria is actually not based on scientific evidence, but rather on moral ideas.
You're not worried about having increased availability of methadone leading to an increased risk of overdose to non-tolerant people who can now not get hold of heroin? I'm playing devil's advocate.
No, I know, but this is what I pointed out in the beginning. We have no issue with supply now, right? It even seems that the quality of heroin and cocaine in the streets is mildly better than before. This is at least what people report. What we do have is a problem with money to buy, right? And of course, people who get now a take home, I mean, they are not going to sell it to buy anything else. It's a ridiculous idea. They keep it for themselves. And on the other hand, there is nobody to buy it because they have no money. So, right?
So if you're going to do something radically different, do it in a situation where things are radically different, which is what you've done. Radical solution to a radical problem.
Exactly, right? I mean, you would probably go and buy some methadone in the streets if you had money and if there were no heroin. Currently, the opposite is true. You have no money and there is heroin. But this is not the situation where you go and buy on the black market methadone. This is the situation where you go to a doctor to get methadone for free. Oh. And actually, that is the way actually you should deal with somebody who is in need of opioids in a situation where the person cannot afford the opioid he or she wants. Right?
Till, I think it's an amazing place to end because you're providing a very pragmatic response to a difficult situation that puts the patient at the center of the decision making, encourages responsibility, but you're also challenging doctors to having to radically revise what they've done. And what you're saying to them is, if you do things different, it'll probably be better, actually, for the clients you're treating. That's food for thought, Till.
But I'm very sure about it, that it will be better if we do it as if Corona were around, even in the future, because it allows people to develop their own lives. And, another interesting issue is usually when a patient with the high barriers came to my office, usually they had some high goals, right? I want to leave behind using drugs. I want to become pregnant. I want to become a good person. I want to become an astronaut or whatever. But very big goals. Now we have quite a lot of patients who are coming in with much more humble goals, right? They say, well, I want to survive this situation. And maybe later I go back into what I have done before. I need a break or I need a bridge until times get better. And that is, from my point of view, therapeutically gold, right? That you really have a person who just can come to my office and relax, let's say for 3 months, 6 months, as long as the person wants to relax without making money, without going for dealers, without having problems, just relax, but without, at the same time, without these big goals of, I want to be clean for the rest of my life. I want to become a father of 7 children and drive a little car around. And, just be a helper in the very situation. And this has become quite fashionable now.
Right? And those goals also marry with the goals of the treatment services. And obviously where you can meet, the goals of your clients and they meet your own goals, that's where you're going to have a better outcome. Till, thank you so much. It's been really inspirational. And my guess is lots of people are going to watch this. And if they're on treatment, they're going to say, why can't I have treatment with that man in Berlin? So I think it's an amazing model. And I think what I'd like to do maybe in a couple of months is come back and do a follow-up and see how things are doing. But until then, thank you so much for sharing your experience and for the work you're doing. And stay safe. It's been really interesting.
Thank you very much, Adam. Thank you. My pleasure. Right.
Just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, cause I'll be fine. Yeah, I'll be fine. Yeah, no longer focused on yesterday. And I don't care, the rest will say whatever they want. What's left to say? What's left to say?